And welcome to the lecture on infections of the oral cavity. I am Dr. Vaibhav, reader in the Department of Oral and Maxillofacial Surgery. How do you define an infection? An infection is a state produced by the establishment of one or more pathogenic agents in or on the body of a suitable host. These pathogenic agents could be bacteria, protozoa, or viruses. So, the invasion, multiplication, and establishment of such organisms that are not normally present within that particular site can be called as an infection. An infection may not necessarily cause symptoms. In such cases, it is called as a subclinical infection. During the course of this lecture, we will come across the term spaces many times over. So, what are these spaces that we are talking about? Shapiro defined facial spaces as potential tissue spaces. The facial spaces are potential spaces between various layers of fascia which are normally filled with loose connective tissue and bound by specific anatomical barriers. These spaces, depending on those anatomical barriers, may either get eroded, extended, or distended when filled up with purulent exudates when an infection sets in. Like I told you, Shapiro defined facial spaces as potential tissue spaces. These are potential spaces because these are not actually present till pus fills them up. In his landmark study, Grodinsky and Holyoke defined what are now known as deep neck spaces and gave all of these specific numbers. The spread and localization of odontogenic infections is caused by various anatomic factors. So, what are the predisposing factors which help in onset of an infection? A. Microbial factors and B. Host factors. So, what do we mean by the microbial factors? It could either mean the virulence. Virulence is the ability of a microorganism to cause an infection, and also it may depend on the quantity. That is, an infection may be caused by the sheer number of microorganisms present within that particular site. So, what are the host factors? Host factors include all the immunity about which we have already studied in our second year, which includes local humoral factor, local factors, humoral factors, and cellular factors. These are the host factors. Now, a third factor has been added. These are the environmental factors. So, an imbalance between these three factors may lead to specific or better conditions for onset of an infection, which may make an individual more susceptible to infections. So, like we spoke about, local factors may include epithelial linings, secretions, microbial flora, the immune system. General factors, the medical condition of the patient, immunity factors, okay, phagocytes, lymphocytes, all these are your cellular defense mechanisms. So, certain medical conditions make a patient more vulnerable or susceptible. We are aware of all such conditions. Examples: diabetes, liver disorders, tumors. So, like we spoke about this earlier, virulence refers to the quality of microbes, that is, the ability of a microorganism to cause a disease. Okay. Infections of odontogenic origin may range from, like we all know, periapical abscesses to deep neck infections, which could have a bearing on the patient's life. So, how do you classify infections? The most simplest classification is based on etiological factors. It could be odontogenic. So, odontogenic includes pulpal diseases, periodontal diseases, periapical infections, pericoronal diseases. It could be traumatic. It could be iatrogenic. What do we mean by iatrogenic? Iatrogenic is any kind of an infection resulting from a doctor's meddling. All right. So, if an infection results because of some sort of a meddling or treatment provided by the doctor, it could be called as an iatrogenic cause of infection. It could include any surgery, for example, traumatic surgeries, implant surgeries, infections arising from usage of contaminated unsterile instruments, needles, all such things. So, that was the first classification. The second classification is on the basis of causative organisms. So, it could be bacterial, fungal, viral, parasitic. So, this classification is mainly based on the etiological factors, that is the organism causing the infection. So, how do we go about treating a patient who comes to you with an infection? We will come across this principle several times during the course of this lecture, because it is very important. So, the first thing that you need to do is make sure you know and you realize the severity of the infection. You have to determine the severity of the infection. You have to evaluate the state of patient's host defense mechanism. You have to treat the infection. You have to treat the infection, as in you have to treat the source of the infection. Antibiotics, like we will come to know later, are only supportive measures. And then once the patient's infection comes down and the symptoms come down, you have to do a thorough follow up of the patient, so as to prevent recurrences or any complications. So, the 5 keys to treat any infection: you have to diagnose properly, you have to take care of the etiological factor, you have to treat it surgically in any appropriate way, appropriate antibiotic, suitable antibiotic therapy, and of course, supportive care. Signs of inflammation, we have all studied this during our second year pathology classes, right? Dolor, tumor, calor, rubor, loss of function. So, an infection produces these 5 classical signs of infection. Again, we have come to the principles of treatment. The most important and the most fundamental thing that you need to do is to determine the severity of the infection. So, how do you do that? You do that by taking a good proper history, right? So, you need to talk about the chief complaint of the patient. Under the chief complaint, you have to find out what actually is bothering the patient, whether the patient has pain, difficulty in eating, difficulty in swallowing, difficulty in breathing, a swelling, whatever. So, you need to find out why the patient has come to you. The onset, duration, symptoms, all these play very crucial roles in treating the infection. And the most important thing is you have to ask about medical history, because that is also very important when it comes to how you go about treating this patient. Vital signs, recording of vital signs is very important in a patient who comes to you with a possible source of infection, right? The most cardinal sign is fever. Okay, so any patient who comes to you with a temperature above 100 degrees could mean some sort of an infection somewhere. There could be a mild elevation in blood pressure, the pulse rate would be increased, you call this tachycardia. The increased respiratory rate is also seen, known as tachypnea. The patient may appear weak, the patient appears in a state of malaise. What is malaise? Malaise is a general feeling of being not well, right? The patient may feel extreme weakness, the patient may be dehydrated, the patient may not even be able to speak properly in certain cases. All right. So, then once you take a history, then you move on to your examination. You first observe extraorally. Extraoral examination includes, looking out for any signs of infection like redness, any swelling, all those things. All right. Then you notice the extent of the swelling, if there is any. Okay. Then you notice the general well-being of the patient. Then you move on to something called as palpation. So, all examinations are done under certain headings, right? Inspection followed by palpation, intraoral and extraoral. Okay. So, when you palpate, you feel for the consistency, you see if there is any pain when you touch you see if there is any tenderness, you see if it is soft in consistency, if it is hard in consistency. All right. So, these are things that you check for. Then you move on to intraoral examination, you check for the amount of mouth opening the patient has, you check if there is any obvious source of infection within the oral cavity, you check if there is any intraoral swelling, you check if the patient's tongue is in the normal position, you check if the patient is able to move the tongue properly. So, all these are the things that you need to check for. Moving on to imaging, right? Imaging does not play a major role when it comes to diagnosing an infection. Okay? Infections most often are very evident, you do not need imaging. Imaging may be useful in certain times when you need to actually isolate or identify the etiological factor. So, what kind of imaging can we use? We can use imaging right from your simple IOPs to CTs to magnetic resonance imaging. Okay. So, MRIs and CT scans are very helpful when you are trying to determine the extent and severity of deep neck infections. Moving on to the microbiology of the infection. We have studied all this. Again, we will not go into all this because all of us are already aware of the microorganisms and the kind of microorganisms that can cause diseases in the oral cavity, right. So, microorganisms for all practical purposes can be broadly classified into the bacteria, especially can be classified into aerobic and anaerobic bacteria. So, you have your different rods, bacilli, cocci, all right. Yes. So, why is this important? This is important because identification of the organism leads to a better evaluation of the patient's condition, right, and also helps us in planning the treatment better, because the moment you know what kind of organism is causing the infection, you can treat the patient in a more holistic sort of a way. So, how do you identify these microorganisms? Like I told you, isolation, identification of these microorganisms is important for diagnosis and appropriate therapy. Okay. So, how do you do that? You do it by a method called as culture and sensitivity testing. All right. So, when do you go in for culture and sensitivity? Not all patients who come to you require culture and sensitivity testing. All right. So, when do you do it? You do it when the infection is a rapidly spreading infection, when the infection is of a post-op kind of a nature. That is, you have treated the patient surgically for something, post the surgery or post the procedure, the patient has developed infection. Or if the infection is non-responsive, that is, you have treated the patient either surgically or medically, or sometimes you have treated the patient both surgically and medically, but still the patient is showing symptoms, the infection is not subsiding completely. In such cases, you may have to go in for culture and sensitivity. Recurrent infection, the patient had completely recovered, but comes back to you again after a week with the same kind of an infection at the same place or an adjacent site. So, that could be a recurrent infection, or in cases wherein you know that the patient is a compromised patient, that is, you know that the patient has some sort of a medical problem. So, what are the stains that we know of? The most common one is the gram staining, right. You have your gram positive, gram negative bacteria. So, how do you collect specimen? The most common three ways include using a swab, aspiration, that is, you use a wide bore needle and aspirate using a syringe, and you take a biopsy, right. So, these are the three broad headings under which you can collect specimen for testing or culture and sensitivity testing. Okay. So, culture and sensitivity, what do you mean by that? Culture, okay, you take the organisms and try to grow it in a specific culture media, right. What is sensitivity? So, the organism that you grow, you again expose them to several common used antibiotics and see what is the reaction to that specific antibiotic, whether the organism is responsive or sensitive to that particular antibiotic. Okay. So, this helps us in using the right antibiotic for that particular infection. Okay. Yes. So, like I told you, in the treatment, most important is the removal of the cause of the infection. So, we already did this. So, you have two specific type of antibiotics. Again, you have your bacteriostatics and cidals. There are certain specific combinations that are not supposed to be used. There are certain specific combinations that are useful. Okay, we will not go into all this because we are aware of all this, and it will simply prolong the lecture if we go into the pharmacological aspects of it. Okay, how do you select an antibiotic? This is very important. All right. So, how do you select an antibiotic? Use empiric therapy routinely. What do you mean by empiric therapy? Suppose a patient comes to you with an infection. Okay, there are several studies which show that that specific infection that you have seen in a patient could be caused by a particular set of microorganisms. So, using that knowledge, you can guess that okay, these are the organisms causing this kind of a disease in this person. So, based on that knowledge, you can prescribe antibiotics which have proven to be useful against those microorganisms. So, this is the empirical antibiotic therapy. Okay. The second thing is use the narrowest spectrum antibiotics so as to reduce the chances for antibiotic resistance. Use antibiotics with the lowest toxicity and side effects, use bactericidal antibiotics if possible, and always be aware of the cost of antibiotics. Alright. So, these are the basic principles that you use when you are selecting an antibiotic. So, what are the different types of antibiotic therapy that we have? Now, before that, when do you use antibiotics? Okay. This is very important for us as general practitioners to understand when do you need to prescribe antibiotics. Okay, do you prescribe antibiotics for all patients who come to you with pain? Do you prescribe antibiotics for all patients who come to you with swelling? No. So, what are the broad guidelines? Use antibiotics in cases where there is a rapidly progressive swelling, a diffuse swelling, compromised host defenses, when there is an involvement of multiple facial spaces, severe infections and osteomyelitic cases. Situations in which use of antibiotics is not necessary when you have a chronic well localized abscess. Abscess is basically a sac filled with pus. So, your body is already trying to limit the infection, right. So, in such cases maybe use of antibiotics is not judicious. All right. Selection of an antibiotic therapy, you have 3 basic antibiotic therapies that we are aware of, right. Empirical, we have already spoken of that. You have something called as prophylactic antibiotics. So, prophylactic meaning you prescribe antibiotics hoping to prevent any infection from setting in. All right. So, what are the advantages? It reduces the incidence of infection, it reduces healthcare costs, it reduces the total antibiotic usage and allows for. But what are the disadvantages? It alters host flora, may allow for bacteria resistance and may encourage lax surgery. So, when do you prescribe prophylactic antibiotics? When you feel that the risk of infection is significant. All right. So, antibiotic plasma levels may be high. What do you mean? What I mean to say is prophylactic antibiotics, the duration and the dosage should be similar to a therapeutic dose, right. You cannot give prophylactic antibiotics for just a day and hope to get away with it. No, prophylactic antibiotic dosage as well as the duration should be similar to your therapeutic dosage. Now, coming to a very important part which is asked very commonly in viva voce situations. What is the difference between an abscess and what is the abscess and a cellulitis case? An abscess, like we already spoke about, is a circumscribed collection of pus in a pathological tissue space. An abscess is, please note, a thick walled cavity containing pus. All right. So, what is cellulitis? Cellulitis is spreading infection which spread across available tissue spaces, across loose connective tissues, right. So, how do you differentiate between a cellulitis and an abscess? Cellulitis is most often acute in nature, right. Chronic. Abscess is chronic. Okay. Basically your body tries to limit or contain the infection in a sac, right. So, that is an abscess. So, abscess is generally a chronic kind of an infection. Pain because of a cellulitis is severe. An abscess, it is localized and not great. Size, cellulitis, the size is huge. An abscess, size is comparatively smaller. Localization, localization meaning borders. Can you very accurately describe the extent? Difficult in cellulitis, that is, in cellulitis the borders are diffuse. In an abscess you can do that, right. An abscess is often well circumscribed. On palpation, a cellulitis would be doughy and may be indurated. An abscess is most often fluctuant and soft. Pus is not often present in cellulitis, but it is always present in an abscess. The pain, that is degree of seriousness, the pain and other complications are much higher in a cellulitis case, much lower in an abscess case. You generally see aerobic bacteria in a cellulitis, whereas you generally see anaerobic or mixed kind of bacteria in an abscess. So, management, like we already spoke about all this, the most important thing is you have to diagnose, right. Yes. Again, how do you drain an abscess? The method of draining of an abscess is called as Hilton's technique for incision and drainage. No matter what the infection, this is the most commonly used method to incise and drain an abscess. How do you do that? You use certain specific instruments, right. We will come to those instruments in the next few slides. First, you need to prep the area. How do you do that? You scrub the area with betadine or some sort of a microbicidal solution. You try to anesthetize the area with some kind of an anesthetic with vasoconstrictors so as to reduce the bleeding as well. Right. Then you place an incision and the most dependent area of the swelling using a number 11 blade. The kind of incision to be placed is called as a stab incision. Alright, the incision should be placed in a skin crease and if possible parallel to the Langer's line for aesthetic results. Since face is in a high aesthetic zone, you need to take care about the aesthetics as well. But most important principle is you have to place the incision in a dependent region. Following that, you have to be careful about where you are placing depending on the aesthetic site. Then you enter the space with a closed hemostat or a sinus forceps, Lister's sinus forceps. Alright, we have all seen this forceps in the department, right? Yes. You enter the abscess, then you open the beaks of the forceps so as to break the locules. What are these locules? Basically, within an abscess, you have a beehive shaped structure. These individual hives, if I can call it that way, is called as a locule. So, in order to drain the pus, you need to break all these small sacs within the big abscess. So, you need to break all these locules. Alright, once you have drained all the pus, you need to establish a drain so as to allow for drainage of all the inflammatory materials and the pus once your procedure is done. So, this is how you do it. Okay. So, local anesthesia, again I will repeat, you inject some local anesthesia, incision is made in the most dependent region, the scalpel is pushed. Alright, so that is your sinus forceps that you are seeing in the picture over there. Okay, now moving on to the anatomy of facial spaces. Spaces associated with the maxilla, you have several classifications, okay, like we spoke about, you have Grodinski and Hollyoaks classification, several others. The most commonly used one is depending on the anatomical location, right. So, you have spaces associated with the maxilla, spaces associated with the mandible and neck spaces. Okay. You also have primary spaces and secondary spaces. What do you mean by primary spaces? Primary spaces are spaces that are infected, that are involved directly, that is an infection from the source spreads directly to that space. That space is called as a primary space. If the infection spreads indirectly or through some other route, then that space becomes a secondary space. Alright, yes. So, spaces associated with the maxilla, we will be talking mainly about the buccal, palatal, canine space infections. Canine spaces, again will not go into the boundaries. I request all of you to please open up your anatomical textbooks, anatomy textbooks, so as to get a good idea about the boundaries. Very important to know about these boundaries, because then you will be able to talk about the clinical features and treatment in a much more clearer way, so that you do not have to mug stuff up. Okay, you can visualize these spaces. Yes. So, it is the area between the anterior surface of the maxilla and the overlying levator muscles of the upper lip. These are the boundaries of the canine space. It contains the infraorbital nerve and branches of these nerve. So, the most common reason for a canine space infection is infection that spreads through odontogenic causes, that is your central incisors and the canines. Okay. And the canine route, as we all know, is one of the longest routes. So, the infection from a canine can spread directly to the canine space. How does it look like? You will see an infection, you will see a nice big swelling in the cheek region, right, just below your eye. Sometimes the side of the nose may also be affected, and there is obliteration of the nasolabial fold. That is a classical sign of a serious canine space infection. Infection can spread from one space to the other. For this, knowledge of these boundaries very important, right. So, that if you know the boundaries, you can imagine or you can visualize how the swelling could be, or how the infection exists and how the infection could spread to the adjacent sites. Complications of canine space infection, cavernous sinus thrombosis. We all read about this, right? Cavernous sinus thrombosis. There are all these different ways or routes through which it can reach the cavernous sinus. We all read about the danger area of the face, the Rittles area. Yes. So, how do you incise and drain? You use Hilton's method. You use basically all the principles of Hilton's method. Moving on to the buccal space. It is the subcutaneous space between the facial skin and the buccinator muscle. Basically, your cheek, right? Lateral to your canine space is your buccal space. Boundaries, these are the boundaries of the buccal space. Contents, you have your buccal pad of fat, Stenson's duct and the facial artery. So in a canine space infection you will see a swelling in the cheek, right? Yes, so this is how it looks. This is important. When does the infection become a buccal space infection, and when will you call it a vestibular space infection? This depends on how the pus travels across the buccinator muscle. If the attachment of the buccinator muscle and the location of the abscess determines whether it becomes a buccal space infection or a vestibular space infection. It's very important because several important spaces are adjoining the buccal space. So an infection from the buccal space can spread to other adjacent spaces if not treated early. So how do you treat it? You treat it with incision and drainage. We need to remember is all infections have to be treated according to the principles of infection that we spoke about, right? Yes, starting with determining the severity of the infection, supporting the patient medically if needed, then followed by treatment of the cause, then followed by incision and drainage, followed by medical therapy and further supportive therapy, and lastly but not last, follow up. Palatal space. Palatal space, again we all know there is very little space beneath the palatal mucosa, so palatal infections are extremely painful. The most common causes of a palatal space infection is either infection or because of your premolars, upper premolars, or the lateral incisor, right? Moving on to the spaces of the mandible. These are important spaces. You have your submental, sublingual, submandibular, pterygomandibular and the submesenteric space. So boundaries of the submental space. These are the boundaries of the submental space. Submental space basically is the space that is present near your chin. All right. Clinical features: swelling in the submental region, that is swelling in the midline. Most often the swelling is firm and erythematous. Teeth involved are usually mandibular anterior teeth. The patient may sometimes have difficulty in swallowing. So how do you treat? Again, Hilton's method. Sublingual space. Sublingual space, like the name tells you, is the space that is present below the tongue, right? Yes, so you have all these boundaries. You have your anterior boundary that is formed by the lingual surface of the mandible, superior boundary found by the floor of the mouth, inferior by the mylohyoid muscle, right, medially by the genioglossus muscles, posteriorly by the hyoid bone. So you have your sublingual gland, the submandibular duct, lingual nerve, sublingual artery and vein. So important structures that are present within the sublingual space. The most common source of infection of this space, possibly the mandibular premolars, occasionally submandibular salivary gland. So from this space, infection can spread to several other adjoining spaces like the submandibular space or the sublingual space of the other side. Okay, so the anatomical boundaries are very important to be aware of. Swelling, clinical features, unlike your submental space, there is very rarely any extraoral swelling that is seen. Okay, in such cases intraorally the tongue movements would be slightly restricted, maybe the tongue could be slightly raised. All right, it could be brawny, erythematous, tender swelling of the floor of the mouth, severe discomfort in speech and deglutition, difficulty in swallowing. How do you incise and drain? Again, very important to be aware of the anatomical factors, right? When you're planning an incision and drainage, you have to make sure you don't harm any of the important structures. In the sublingual region, you have several important structures like the sublingual vein, your hypoglossal nerve, so you have to be very careful not to damage any of these structures, right. Now submandibular space. So this is important, right. So when do you say that the mylohyoid muscle forms sort of a boundary between your sublingual and the submandibular space? If the source of the infection is present above the mylohyoid muscle, that is periapical tip of the root is present above the mylohyoid muscle, the infection would go into the sublingual space. If it is present below the mylohyoid muscle, it will go into the submandibular space. So that is how the infection spreads, either to the sublingual space or to the submandibular space. So the attachment of the mylohyoid muscle is very important. These are the boundaries. Very important to know the boundaries of the submandibular space, a very commonly asked question. Okay, the contents: you have your submandibular gland, the facial artery, submandibular lymph nodes and the facial vein. Common source of infection is mainly from the mandibular molars, right. Symptoms: swelling that extends up to the inferior border of the mandible all the way up to the hyoid bone. Intraoral, you have severe dysphagia, moderate trismus. Again, trismus meaning difficulty in opening and closing of the mouth, basically difficulty in opening of the mouth. So when do you see trismus? You see trismus when the muscles of the mastication, you have 4 muscles of the mastication, right. You have your medial pterygoid, lateral pterygoid, you have your temporalis, and you have your masseter. So if any of these muscles gets involved, either primarily or secondarily, you will have trismus. How do you drain? You make an incision 2 centimeters below the lower border of the mandible. You have to be careful about the anatomical structures. In this case, the marginal mandibular nerve. So that's why the incision is made 2 centimeters below the lower border of the mandible. Now, Ludwig's angina. This is the question that is asked very commonly, and it is very interesting. So please pay attention, right. We as dentists come across very few conditions that are potentially life threatening, right. This is one of them. So proper diagnosis, identification, proper response to the severity, and proper referral or treatment is absolutely vital, because if a patient is not treated properly, the patient may go into something called as a respiratory embarrassment within minutes, and in such a case it becomes very difficult to salvage the situation. Yes, Ludwig's angina is a firm acute toxic cellulitis of the submandible and sublingual spaces bilaterally and of the submental space. So an infection which involves 5 spaces is called as a Ludwig's angina. So what are these 5 spaces? You have your bilateral submandibular, bilateral sublingual, and the submental. So if an infection involves all these 5 spaces, then it is called as Ludwig's. If it involves any less than these 5 spaces, that is if it involves only 4, for example unilateral submandibular, bilateral sublingual and submental, then it is not Ludwig's, it is called as pseudo Ludwig's. It is called Ludwig's only if it is involving all the 5 spaces. Okay, this was described by von Ludwig in the year 1836. Ironically enough, this poor chap died from a neck infection himself, although it was not Ludwig's, but he died of a neck infection. What do you mean by angina? Angina is a feeling of choking or suffocation, because that is the end result of Ludwig's angina if not treated properly. The patient chokes. Clinical features: the patient will have fever, discomfort in swallowing, difficulty in mouth opening, floor of the mouth becomes hard, red, indurated, tongue would be raised, patient will not even be able to speak, voice becomes hoarse, there will be severe dyspnea. If there is dyspnea, then it is an emergency. You need to treat the patient ASAP, immediately, right. So these are all the clinical features. So again, you have your extraoral features, intraoral features. So all your extraoral and intraoral features would be very similar to the individual space infections that we spoke about, right. So you will have your swelling in all these spaces that are involved, you will have redness, you will have tenderness when you touch. Okay. Hallmarks: there will be bilateral swelling of the sublingual and submandibular spaces and the submental space, like we spoke about, total 5 spaces. There will be a brawny edema, the tongue would be elevated, there will be an airway obstruction, and initial stages there will be a paucity of pus. How do you treat? Very important. Okay, you have 2 lines of treatment, you have a medical and surgical, but most often you have to combine both of them so as to ensure proper clinical treatment. Yes, the first thing that you do is you have to diagnose early. Most often this is the easiest thing to do, because a patient with Ludwig's angina will give you so many telltale signs that it is very hard to miss, right. You have very specific clear cut signs and symptoms, so it is very easy to diagnose. Okay. The next thing is you have to make sure the patient's airway is patent, that is you have to make sure that the patient is able to breathe properly. Like I told you, in case it is not treated properly, or in case the patient is medically compromised in some way, it may lead to a respiratory embarrassment very quickly. So you need to maintain a proper airway. How do you do that? You do that by checking the by using a pulse oximeter and checking the oxygen saturation, right, and also to see how the patient is breathing, whether the patient has any kind of dyspnea. In case the patient is not able to breathe properly, you will have to undertake measures like intubation. Intubation is basically introducing a tube within the throat of the patient so as to ensure a patent airway, or you have to, in case it's an emergency situation, the patient is in severe dyspnea, you need to perform procedures like cricothyrotomy or procedures which involve making a surgical airway like tracheostomy. Yes, all right. Next is you have to start the patient on antibiotics, right? You have to start the patient on empirical antibiotics, and if possible take some sample and send for culture and sensitivity so as to start on specific antibiotic therapy. Then you have to take care of the cause, all right. That is, you have to take care of the etiological factor. Most often it could be some odontogenic infection. Then you have to make sure the patient is hydrated and well fed. Because of the general medical condition of the patient during the Ludwig's angina, the patient may not be taking in food or water normally. So, you need to make sure the patient is well hydrated, you need to make sure the patient glucose levels are up to normal levels. So, you need to start with IV lines if possible, and you need to support the patient parenterally, okay, and then surgical drainage. How do you do this drainage? Again, you use the Hilton's method, but in this case you perform something called as a through and through incision. That is, you enter from one submandibular region, you pass your sinus forceps through the submental region and enter the sublingual and the submandibular region on the other side. So, you have a through and through drain, like you can appreciate in the picture. It is called as a cut throat incision, and you establish drain by securing, of course, by securing drains, all right. During all this, you have to make sure the patient has a proper patent airway and the patient is not under any dyspneic condition. Now, the last space is the pterygomandibular space, again very important, the boundaries of which are asked very often. We all know this. Superiorly you have your lateral pterygoid, medially the medial pterygoid, laterally you have your mandible, anteriorly the buccinator and the pterygomandibular raphe, posteriorly you have your pterygomandibular, you have your parotid gland. Contents, you have several important structures. This is the space that you inject into to achieve your inferior nerve block. So, you have to be aware of the important structures within the space. Okay, the most common source of infection to a pterygomandibular space is from an infected third molar, right? Yes. So, the clinical features, severe trismus, because you have your muscles of plastication directly involved. You have your medial pterygoid and the lateral pterygoids. So, you have a severe trismus, the patient will not be able to swallow, there will be intraoral swelling, may or may not be necessarily seen. In case it is seen, it could be present on the medial surface of the mandible, of the ramus of the mandible. Incision and drainage, incision is made on the anterior border of the ramus of the mandible. Most often you make an incision intraorally. Very rarely do you need to make an extraoral incision. In case you do, it is made in the skin below the angle of the mandible and you drain it using your Hilton's method. Submasseteric space is the space that is present below the masseter muscle. You have your boundaries. Again, in a submasseteric space, contents include your mesenteric nerve, the mesenteric artery and vein, and the transverse facial artery. You have severe trismus, the patient will not be able to open at all, the pain would be tremendous, it will be extremely tender on palpation. Okay, again you find the most appropriate site to incise and you go out and drain the infection. With this, we come to an end of the lecture on infections of the face. If you have any questions, you can always come to the department, ask any of us. Thank you for your patient hearing.